But I have all these friends in traditional medicine, hospitalists, people who, take care of older adults who still like think that I'm practicing voodoo medicine. They think that I'm completely like just making things up. Like I'll talk to them about hormones and they're like, yeah, that's whatever. Like it's just crazy to me.
Welcome to the Dutch podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jacqueline Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi there. Welcome to this week's episode of the Dutch podcast. I'm really excited for today's guest, Dr. Amy Killen. I follow her on social media and I find that she has this science-forward approach. She shares really great information and I've always learned a lot from her. Really diving into her story as well, it's pretty incredible, how she went from an ER physician to a longevity medicine doctor. Now, in today's episode, we get to touch upon a lot and we dive into a lot more of the science of hormones, which is really what she does in her practice day in and day out. She takes this approach of hormone optimization, and we really talk about what that means for women, particularly during perimenopause and postmenopause. And what I really appreciated about this conversation was we got into a lot of the physiology and a lot of the why behind the standard recommendations that are there. We talked a little bit more about the research. We talked about the timing that's recommended for starting hormone therapy and why you might make a decision that's outside that normal guideline. We really got to talk about a lot of the in-depth areas. The other thing we covered on this podcast that was newer to me, not something I've done in practice, is the longevity medicine approach, the testing that's done to determine things like biological age or organ age, and why that's an important piece for us to be considering in your practice, but also as a patient, as you think about living a really healthy latter half of your life. So I learned a ton from this podcast. I think you're going to really enjoy it. We also talked a bit about the Dutch test and about the research behind the Dutch test, and really got a chance to talk about a wide variety of aspects of health for women. So my guest today is Dr. Amy Killen. Like I said, leading expert in longevity and regenerative medicine. And she really does have that approach to move people from surviving to thriving. She talks about this when women come in, they're in a little bit of state of overwhelm, but then once they start to feel better, you can really work towards that thriving point of view. After she began her career as a board-certified emergency physician, she shifted her focus to human optimization, blending hormones, peptides, and regenerative therapies to support vitality at every age. She's the co-founder and chief medical officer of Humanot Health and the founder of the Human Optimization Project. Dr. Killen's very passionate about empowering women to reclaim their health and confidence, and she's widely recognized for her engaging, science-based approach to aging and wellness. You're going to love everything we talk about today, so let's go ahead and dive in. So, Dr. Killen, you're one of the guests I'm most excited to have on the podcast, so thank you so much. I'm so glad you're here.
Thank you. I'm very excited. It's going to be a good conversation, I think.
So one of the things that I really loved hearing about is hearing about just your backstory, which I find really fascinating because you've had this like twisted, winding road to get to where you are now in the longevity medicine space. And it was really sounds very intense and very humbling and, just a big change for your life. Can you start by, for our listeners who don't know you that well, share a little bit about your background clinically, but also just kind of that personal changes that you've been through to get where you are today?
Yeah, thank you. So I was an emergency physician first. So I was an ER doctor for 10 years, went to residency and worked in the ER in Austin for a long time. And it was super fun, lots of adrenaline, lots of cool stuff. But then I had my 3 kids within 2 years and I was working in the ER still, had to be at work at 4 a.m, lots of stress, lots of Diet Coke and Monsters and not eating well. And just lifestyle wasn't great, but just trying to juggle it all. And I kind of started to get overwhelmed. And I realized at one point when I was in the ER, I was looking out at the people who were waiting to be seen as patients. And I just had this moment where I realized that if I didn't make some big changes in my life, I was going to be one of those patients in the ER in a few years with some kind of chronic medical problem that could have been prevented if we'd gotten to it sooner. So I decided I needed to make some changes, and I eventually left emergency medicine. That was in 2013, and started learning about this other kind of medicine: integrative medicine, functional medicine, longevity medicine, hormones. There's a lot of different names for it, but essentially, how can we prevent problems? How can we optimize health? And that's what I've been doing ever since then.
Mm. I want to talk a little bit about, you said 3 kids in 2 years, that's intense, let alone like on top of a job. And I think that's an interesting piece to talk about. I love talking about that combination of like mothering or parenting, not just mothering, but mothering and doctoring, because I think that's it's hard to wear all the hats at one time. Can you share a little bit about what that was like what that season of life was like with you? Because that's a lot to juggle.
Yeah, it was crazy. I had twin daughters, and then 20 months later I had my son. And when my son was a week old, my husband, who's a screenwriter, he got a job out of state and moved to California. And I was living in I
Wow.
was living in Texas. So I was basically the lone caregiver of these 3 kids, and I did have an au pair who would work sometimes, but essentially whenever I wasn't working in the ER, I was taking care of the kids, and there was no real help. And I had to be up at 3:30 in the morning, so I was sleeping 3 or 4 hours a night total, which was crazy. And I was just in survival mode the whole time. Like, I look
Whoa.
back, I don't even remember a lot of it because I think that I was just in this state of just, I think as women especially, we just kind of are like, I can do this. Like, I'm not going to
Heads
call in sick.
down.
I'm going to keep
Right.
going. Like, there's no stopping. Like, you got to keep going. And so I just kept going. And then eventually, after a few years of that,
Mhm.
I took a moment to kind of step back, and I just realized kind of the wear and tear to my brain, to my body, to my family, and that I couldn't keep going like this forever.
Yeah, it's interesting because a lot of people ask, because I'm a mom. I've got 4 biological kids, but I'm a blended family, so we have 7 in total. It's very busy, of course, wearing multiple hats at a time. And people ask a lot about that. And I think we also had au pairs when my children were young. And I think that that's such a wonderful way to kind of smooth the edges and allow you, for me, I feel like it allowed me to be the mom I wanted to be when I was around, because I didn't have that long list of like pack the lunch, do the laundry. Like, they held together so many of the aspects of parenting. There's privilege, of course, that we had that, but
Yes.
they were able to really make sure that when I showed up, I got to like show up as a mom in the way that I wanted to be. And so I'm really happy that you mentioned that, because I think some people think that working women kind of do everything by themselves, but a lot of times it does take a village, and it's
Oh,
okay to have a
absolutely.
village.
Yeah. And my husband was, when I had the twins, was very, very helpful. He was here for those first few years. It was the two of us against the world, just
Yeah.
juggling the babies. And it was like constant. But, the au pairs, I had many au pairs, and they were fantastic. And they did help a lot, but they only worked, 10 hours a day, which
That's
is
right.
a lot, but I was working 10 hours a day. So, essentially
Mhm.
when I wasn't working at my ER job, then I was fully taking care of the kids, which was great. Like, I wanted to do that, but at the same time, there's never downtime. There's never rest. There's
Yeah.
never time to go to the gym. There's not time to make, home cooked meals. Like, all of that stuff really kind of had to like fell by the wayside.
Yeah. I was listening to a podcast yesterday of like a high powered businesswoman who doesn't have children. And they were asking, like, well, what do you do when you don't work? Because she's like, I work all the time. And she's like, well, I love to get facials. And it was just such a stark contrast to my own life. I'm like, oh,
Yeah.
I would love to get a facial, but when am I going to fit that in? Like just the difference when you're trying to juggle as a parent. And there's no shade thrown, because I think everyone can choose the life that they want. But I think it's, until you have that responsibility and you're trying to do all those things, whether you're a man or a woman, you don't know
Yeah.
what it's like, really, that there is no free time,
I
really.
I remember one time, I have this very vivid memory when my kids were all little. My husband was out of state, and I was talking to one of my girlfriends about, like, I actually had a dinner out. So we're talking about, parenting and kids and something, and I mentioned that I had made fish sticks for dinner the night before for the kids. And my friend, who didn't mean any harm, but she was like, "Oh my gosh, how are you making, like, fish sticks are so bad for your kids. They're so horrible." And I all of a sudden just felt so guilty. And because the worst part was, like, fish sticks were like one of my better meals. Like, I did
Mm,
not have time to cook. And even putting something in the oven for 20 minutes was like, I felt really good about myself.
yeah.
And so I felt like such a failure. Like, I can't even get like fish sticks is as good as I could do for my poor kids.
Yeah, and I mean, ultimately, your kids were fed, right? And you were
They
there,
were
and they
fed, and
were
they're
fed,
totally
and they're
fine.
great now. They survived, right? So, I mean, we put so much pressure on ourselves. I think, especially in like integrative medicine, functional medicine, longevity medicine, we know a lot, and so, do you breastfeed or give formula? Like all of those decisions
Yeah.
weigh in a different way when you have the background and you're in our
Yes.
field. I think so.
Yes.
With anyone out here listening, we've got your back. Make the choices you need to make. Kids are probably going to be all
Your
right.
kids are gonna be totally fine. They're gonna be fine.
Yes.
They're very resilient.
Especially when they're young, it feels like you're in a blur. I completely relate to that, but you come out of it, they come out of it. How old are your children now?
My daughters are 17 and my son is 15.
Oh, you're really on the other side of that now.
Yeah, yeah, they're almost out of the house, which makes me very sad.
Oh, I know. My oldest is 17 and graduating this year, and it's crazy to see that happening.
Yep.
So I want to talk a little bit about like when you're an ER physician and you're thinking you need to pivot, you started to explore a lot of new areas, hormone health, aesthetics, regenerative medicine. What sparked that curiosity for you? And how did you know that this was kind of the new path?
I got interested first in hormones. I had taken a course through AMMG and Synergenics. They had like a week-long intensive course, and I didn't know anything about hormones. And I remember the doctor who was leading the course called me first, and he was like, "So, do you know about like estradiol and estrone and estriol?" And I was like, "I have no idea what those words are that you just said to me. Like, I literally have no idea." But I started becoming interested, took this course, and was just fascinated by all the things that I had never learned in medical school that seemed kind of important about how these different hormones affect, how our metabolism and how we age and all these things. And then once I eventually left the ER, I started working at a franchise for Body Logic up in Portland, Oregon, doing mostly hormones. And that's when I became interested in regenerative medicine. I started doing PRP procedures, and then eventually moved to Utah and started learning about stem cells and other kind of regenerative biologics. And so added that to the mix as well. But it started all with hormones.
Yeah, it's so interesting because you've been at the leading edge. Like PRP was very new and kind of controversial when it first came out, but now like I'm in Boston, like Mass General does PRP. It's like everyone does it.
Yeah.
And now I think stem cells are kind of that next leading edge. How do you as a doc, because I think this is really an interesting question and something that a lot of us sit with when you're evaluating kind of, especially in a clinic like yours, you want to be offering things that are on the leading edge, but also credible. And
Yeah.
so how do you go through the process to discern and like know when you're ready to take something on like that?
Yeah, I mean, the first question is always, does it seem like it's safe? Obviously,
Mm.
and with regenerative medicine, with the mesenchymal stem cells that we're using or exosomes, these are generally very safe as long as you have a good supplier and good technique. But it's always, safety is the first thing, and then does it work? Obviously, is another question. And I think that there's still a lot of questions that we have, like we don't know for sure what the best way to use these therapies are, what the best dose is, the best form. But I start with, is it safe? And then I'm always very straightforward with my patients. We think that this could help. We don't know for sure, or I've seen it work in 70% of patients, but not 30%. Like, kind of using the data that I can find and making sure that I tell patients what I know and don't know, and just have a very candid conversation. I'm also pretty particular about the patients that I choose to do these procedures, especially when I was first starting, making sure that they're healthy, that they don't have, any red flags, or they're expecting miracles. They have, they're smokers and don't heal well. Like, we had a whole list of things that would kind of push patients away from being allowed to come in. But I think just, honesty with the patients and letting them know that this is all, a lot of it's still investigational and it may or may not help, but I think it's worth a try.
I love that you bring up like the patient selection. That's not something that we've talked about before, but I want to dive into that a little bit more because I think there's like you want to make sure they're a good candidate medically, but then
Yeah.
there's also the mindset you mentioned. Like you want to make sure they're not having unrealistic expectations. Can you talk a little bit more about that? Because that seems to me like a very ethical approach to take. One, that you're really transparent, but also something that really makes sure that the patient has the right mindset for it.
Yeah. So at our regenerative clinic, and so Dosieri Clinic, so I work with Harry Adelson. I've been working with him since 2014, just part-time. I'm up there. And we do these big regenerative cases. He does musculoskeletal injections, neck, back, joints, and I do sexual health, skin, hair, and then we'll do intravenous as well. But we don't treat, in that clinic, we don't treat systemic diseases. So for instance,
Mhm.
Alzheimer's or Parkinson's or, autism or things like that. We're very specifically not treating those things because part of it is because we don't have the expertise, and part of it is we just don't want to treat patients that are desperate for a cure and they're willing to spend anything even if they don't have the money.
Mm.
So one of our, prerequisites is we don't do like, we don't let you pay over time because we don't want to have patients that can't afford it to do these procedures. If you can't afford it, as bad as this sounds, we would rather not do it because, these don't always work. And so what you don't want to do is do a procedure that's not going to work. And now you've been put into debt. So we're very careful about making sure that the patients can afford it, that they understand the risk, they understand that it may not work. And then we stay very closely within our lane of expertise, and we don't treat people that we just don't really understand the disease mechanism for.
I think that's great. Well, let's transition and talk a little bit about hormones. So on social platforms, I've heard you use the phrase hormone optimization therapy, not like menopausal hormone therapy or
Yeah.
hormone replacement therapy. Can you talk about why that terminology feels like a better fit for you?
Yeah, and I sometimes will use HRT or MHT. I
Yeah,
use all the words,
right,
but
right.
to me, a hormone optimization therapy is a better fit because we're not just treating menopausal women. I think any of us who are in this space understand that we're treating women of various ages, premenopausal, PCOS, people who have pain with periods, whatever. And I also treat men. So I'm treating men and women, and I'm not necessarily trying to replace the hormones and get them back to what they were before when you were 18 or 20, but I'm trying to optimize hormones. So I just think it's a better term that explains what we're actually doing. And it also is a little bit more, broadly focused on the population of patients that we're treating.
Yeah, I really love that because I think when we look at hormone therapy, particularly like perimenopause and menopause, replacement, I mean, what are you replacing? Because you're not going back to cycling levels like
Right.
a Wiley protocol.
Right.
It's unusual that providers are doing that where they're trying to actually like restore a menstrual cycle. That's quite unusual.
Yeah.
And then the range that you're targeting is usually between postmenopausal and a luteal range. So it's still kind of a much lower level of hormones than you'd have in
Right.
your reproductive years. So it does seem like you're thinking about it from that optimization point of view to mitigate side effects, but then also look at long-term health outcomes, which of
Yeah.
course, those are not FDA approved indications, but really kind of exciting research
Yeah.
that's
And I
happening.
think we're also not just using estrogen, progesterone, testosterone. I think a
Mm-hmm.
lot of us are also using thyroid or, melatonin or, other hormones that might also potentially need to be replaced, DHEA, things like that. So I just like the toy. And I also like saying that I'm a hot doctor. I'm a hot
Hot.
provider.
Brilliant. That's brilliant. Oh, I wanted to think about that. That's so brilliant. We need to get an army of hot doctors out there.
We need all the hot doctors to come together.
Talk about like rebranding this whole process. God, that's so brilliant with the hot doctors. I love it.
It's good, right?
Um, that's right. So, what are your core goals when women come in for hot therapy?
My goals, I always want to see, well, obviously establishing their baseline is important. We do at Humanot, where I'm the chief medical officer. We do a bunch of different labs. Of course, we're doing diagnostics on blood tests, and we're also doing other things like DEXA scans and VO2 max and things like that. So really getting a good picture of where they are from a clinical standpoint. And then obviously the patient history and understanding what they've been through, what their goals are, what their concerns are. I think that if you listen to a patient, a woman or a man, but a patient long enough, you'll learn so many things about them and know what they're most worried about, what they're really want to achieve by seeing you, and then obviously talk about kind of what the options are. And I am very pro hormones, but obviously not every patient wants to take them or can take them. So making sure that we talk about the risks and the benefits and who's a good candidate, and then kind of going from there.
So, I know you just said you're pro hormones. Let's talk a little bit about why. So, I think some of it is, when we look at especially menopausal hormone therapy, it's predominantly designed around hot flash mitigation. If you look kind of historically,
Yeah.
and a lot of the other benefits that were suspected, like cardiovascular protection earlier, Women's Health Initiative, are now starting to be more well studied. I wonder about your point of view because I think in our lifetime we're going to see that menopausal hormone therapy, or predominantly estrogen, is going to be recommended as a primary prevention. Like, I think the research seems to be going that direction. Do you agree with that, or what do you think
Yeah.
about it?
I think it absolutely will be. And honestly, it should be right now. It should be right now. I'm working on an article right now about vasomotor symptoms and brain health, and the fact, we know now that hot flashes, night sweats, especially night sweats, more than hot flashes, but night sweats are damaging in real time to your brain. And we have MRI evidence that it's essentially causing like little micro strokes in your brain when you have these recurring night sweats over and over again. And we know that this is a risk factor for dementia. We know this is a risk factor for heart disease, and all of these things. Like, we have this data, even though we don't have a lot of long-term data that shows that preventing these things with estrogen necessarily prevents dementia. And there's a lot of reasons that's kind of messed up data. But we do know that in real time, if we prevent vasomotor symptoms, we could probably prevent these hyperintensities on the MRI. And I think to me, that's enough. Like, why do we, yes, we want more data, but if we can prevent the things that are probably driving dementia and heart disease, why are we not doing that?
Yeah, it's interesting because when you look at evaluating a therapy, if we go back to a few minutes ago, you talked about like first you evaluate safety. And it does feel like safety's been well evaluated here.
Yes.
It's been with so many women for so long. We know the risk factors. We know how to screen women for contraindications. There's still more to know, I think, on forms of hormone, right? Yeah. Like most of our research is on CEE and progestins, not progesterone and estradiol, like that's most commonly used. However, if you look at some of the early like observational French studies that make it look like progesterone might be better, it's likely that we've well evaluated safety, that we could start to think about using them for broader indications. And I know a lot of clinicians do, probably yourself as well.
Yeah, and honestly, even if we just use estrogen for one of the Menopause Society's indications, which is osteoporosis prevention, that's enough. 50% of women develop osteoporotic fractures those are who are over the age of 60. So if this affects 50% of women, then why are we not preventing it in women? So even if we don't look at cardiovascular disease and dementia, we know that these hormones absolutely help prevent fractures, absolutely help prevent pelvic dysfunction and UTIs and all the like pelvic floor issues. And that's a no-brainer. We also know that vasomotor symptoms cause brain injury in real time. And to me, that's enough that we can start using them. And I agree, totally agree with you. I don't think we know enough about the dosage, perfect doses, perfect forms. Is estradiol transdermal versus oral? Are there benefits to CEE that we just, we kind of dismissed it, but maybe there were some benefits? I think there's a lot of questions still, right? But whether we should be using the hormones, I don't think is really a question.
Yeah, I saw on one of your most recent posts, you were saying you got a call from your mom and she was talking about like, maybe my GP will kind of leave me alone about this. And you wonder like, what is it going to take for things to become a little bit less controversial in mainstream medicine? And I think part of it is just the timing of education. Like I took a course at Harvard this year on menopause management, Harvard Med School, and they are very much pro-hormone. Like it's very modernized. But I think unless you're a menopause provider, like you're studying under the Menopause Society or you're seeking that out, it's taking a long time to translate into the rest of the medical community.
Yeah, it's kind of crazy to me. My mom, I've had my mom on estrogen for 10 years and she's doing great. And her doctors keep trying to take her off of it. She's in her 70s and, she has literally no medical problems except for that she did just have osteopenia. And she broke her hip a couple of years ago. But I have all these friends in traditional medicine, hospitalists, people who, take care of older adults who still think that I'm practicing voodoo medicine. They think that I'm completely just making things up. I'll talk to them about hormones and they're like, yeah, that's whatever. It's just crazy to me.
Yeah, it does seem crazy. And I went to school when Women's Health Initiative kind of was published. I graduated in 2007. So it was, I learned everything like lowest dose possible, shortest duration possible. Yeah. And, unless you seek it out, you're not really re-educated on it, which is probably all of medicine, right? Which is a scary thing that you could see a GP and if they haven't trained and updated what's going on, they could miss the mark.
Yeah, I'm willing to give doctors a lot of leeway because I understand how it happens. Absolutely. I understand that we all we all have our very narrow focus and we're really just trying to do our best for our patients. And especially if you're in traditional medicine, you only have 5 or 10 minutes to see each patient and to do your charting and to, so I understand that it's just absolutely crazy. But I also think it's time that we stop making excuses and start educating ourselves about hormones.
Yeah, it's a system problem really, because I think most physicians have so little time with the patient, so little time for continuing education. It's an entire system that is about kind of moving patients through as quickly as you can. So it's definitely, doctors are not that we have to take responsibility because we care about our patients, but it's not like it's a lack of desire to do good for our patients that drives that kind of thing to happen.
Yeah.
Absolutely. So what do you think is really driving this like massive surge in interest in hormones culturally? Because I think we are in this time of a movement where everyone's talking about it.
Yeah, it's so interesting because I've been doing this, and I'm sure you have too. Like I've been doing this for 12 or 13 years now, and I've been saying the same thing this all these years, and like no one cared. But
It's like, welcome to the party.
yeah, exactly. But in the last, I don't know, 3 or 4 or 5 years, we've had a few kind of big names in social media who've built big followings, who I think are really good at just getting the word out there and speaking the language of regular women who, maybe aren't in medicine, and just are having these problems. So I think that a lot of it goes, a lot of the credit goes to these doctors who have come out and just done a great job with their education, with their PR campaigns, with their book writing. But I think it's helping. It's a good thing for all women, I think.
And when just talking a little bit more about kind of the future with the state of research, I know you stay on top of the research. We talked about how hot flash management and osteoporosis prevention are kind of the 2 indications that are approved right now. Others as well, like for some other hormones like libido and testosterone, things like that. But what do you think are going to become the future indications for this hormone optimization therapy? Like looking at where the data's at and where things are headed.
I think that we will, in the next, hopefully, few years, see progesterone recommended outside, even in women who had a hysterectomy. I think that there's enough data that we know that progesterone has benefits, that it does counteract some of the negative benefits of estrogen, not just in the uterus, but also the breast, the brain, other organs. So I think eventually we'll see recommendations that people who are taking estrogen should also take progesterone, all the time. I feel like the testosterone is really going to be slow moving. I don't know when we're going to have testosterone recommendations outside of hypoactive sexual desire disorder. And I think the reason for that is because the studies that they've done so far on testosterone, many of them use such a small dose that they didn't see benefits outside of sexual benefits. And so people keep going back to those studies and saying, see, there are no cognitive benefits to testosterone. There are no, motivation benefits. There are no muscle building benefits. But I think we have to take that with a grain of salt. They probably weren't dosing it high enough to see benefits. But I think that that's probably down the line if we're going to see that. And I think we'll continue to see a big push for vaginal estrogen. That's become something that's, obviously become talked about a lot on social media, and doctors, are starting to use it more and more. Even my mom's regular urologist finally recommended vaginal estrogen for her, which I was excited about. So that's a big one that I think is going to make a huge difference in women's lives, and I'm super excited about that one.
We'll be right back. Here at Precision Analytical, we've launched the biggest update to our report since 2013. The new and enhanced Dutch report puts the most actionable hormone insights right on page 1, making it faster and easier to interpret. You'll see a reimagined summary page, upgraded visuals for estrogen and cortisol metabolism, and an all-new About Your Results section, what we call the Dutch Dozen, a 12-point framework that helps you understand your patient's hormone story in minutes. It's a smarter, simpler, and more insightful Dutch experience. From now through December 19, 2025, all registered Dutch providers can order 5 Dutch Complete or Dutch Plus kits for 50% off. Give us a call or visit dutchtest.com/order now. Must be a registered Dutch provider. Promotion not available through distributors. Can mix and match Dutch Complete and Dutch Plus kits. Prepaid only, no drop ships. Cannot be combined with any other offer. Kits must be purchased by December 19, 2025. Welcome back to the Dutch Podcast.
Yeah, I'm actually really surprised to hear you talk about progesterone. That's not what I thought you were going to say. And it's actually really exciting because that's something I haven't seen a lot of discussion around the same. I mean, of course, especially for the brain, like allopregnanolone is like so critical for brain health.
Yeah.
So can you talk a little bit more about that progesterone piece? Because I think just to kind of set the stage, right now, if you are a patient who's listening or a woman who's listening, estrogen is really the focus of menopausal hormone therapy right now. Progesterone is recommended really only for women with a uterus so that you don't develop hyperplasia, which is like overgrowth of the lining of the uterus, which can lead to endometrial cancer. So if you don't have a uterus, it's not recommended. And in fact, some clinicians get criticized for even adding progesterone in a woman who doesn't need it. So what you're talking about, Dr. Killen, is like that there are potentially benefits to having progesterone as well. So tell us more about that, because I find that awesome that you brought that up.
Yeah, I think that the part of the problem, of course, comes from back at the WHI, other studies where they use progestins, and the progestins, of course, were slightly associated with increased breast cancer risk, increased blood clot risk, et cetera. So I think that a lot of doctors, lump progesterone and progestins together and say these are not great, and so we shouldn't give them if we don't have to. And by have to, meaning that you have a uterus that we can't give you estrogen unopposed. But I think that there is a good amount of data that the progesterone, the bioidentical form, has so many benefits. And like you mentioned, when you take progesterone, especially if you're taking the oral form, the pill form, it gets metabolized in the liver, it gets made into allopregnanolone, which then goes to your brain, acts on GABA, and is very good for reducing anxiety, helping with sleep, helping with kind of calming your mood. At least for 80 or so percent of women, it can be the opposite for some, but it can be so helpful. And we know that the brain needs progesterone. In fact, the brain can make progesterone on its own, but it would also like it for you to have some progesterone in your body. So I think progesterone for that purpose, also for counteracting the estrogen in the breast. There's a lot of data coming, and there's some already out there that the progesterone, it modifies the way estrogen works in the breast tissue, and it kind of helps reduce some of that proliferation that estrogen can cause in the breast. And so I think that we should be taking it for the breast. Progesterone also has bone benefits. Certainly, they're not as strong as estrogen's bone benefits, but both progesterone and testosterone have bone benefits in women. And so, we should be studying those. We should be considering them. But, it just makes sense if we're giving a hormone like estrogen. Estrogen is so powerful, and it's just like this loud, amazing hormone. But you kind of need the thing that's gonna balance out estrogen and work with it and tone it down a little bit, and that's progesterone.
Yeah, I thank you for going into that a little bit. It is interesting because hormones are not, well, we think about things in two ways. There's hormone production, but then the way tissues use hormones shifts depending on what hormones are around. And I think that's a piece that we try to, of course, for the sake of explaining, we kind of oversimplify sometimes, but you're absolutely right. Like in a cell, if estrogen is supplied and not progesterone, the behavior of the cell is different than if both are supplied. And I think we sometimes forget that it actually affects. Same thing with insulin. Insulin's another one of those where when there's a lot of insulin around, cells behave really differently. So it really can change the kind of the tissue environments, and that impacts the way we use hormones and probably affects risks for use of those.
It's so there's so many things we don't know, right, about hormones. And we can measure blood levels, we can measure urine levels, but there's all these pieces in the middle that we still really don't know. We do know that progesterone, affects the way that that estrogen binds to the receptors. It affects the shape of the receptors, when you have progesterone there versus not there. And so I think that, it makes sense that if your body made these together and we understand kind of how they work, that you would maybe want to take progesterone as well as estrogen.
Yeah, absolutely. I mean, one of the other kind of really well-documented examples around that environment is that we have this kind of timing hypothesis for initiation of hormone therapy, which was a big issue in WHI. But when women go a long time without hormones being supplemented and then you reintroduce them, the impact's very different from a continuous supply. Do you want to chat about that a little bit too? Because I think people know 10 years or over 60, not such a good idea, but maybe don't understand the why behind that recommendation.
Yeah. So when we think about estrogen, for instance, we have a good body of data that early start estrogen, and this again, mostly oral estrogens. This is CEE with estradiol as well, but early estrogen use within 6 to 10 years of menopause will reduce cardiovascular disease risk in 20 something studies, like a big studies, lots of studies. So we do think that it is helpful for heart disease risk, but that if you start estrogen later, after 6 to 10 years, depending on the study, then we don't see a reduced cardiovascular disease risk in those people. And when I think about this, I think about estrogen's benefits on the blood vessels and cardiovascular system kind of in two categories. I think about direct benefits, how does estrogen directly affect the blood vessel? We know, for instance, that it causes vasodilation through nitric oxide pathways. We know that it can actually improve endothelial function by binding to the receptors there. So we have direct vessel benefits, but then you have indirect vessel benefits, like the estrogen we know can help with your lipids. It can, it decreases your visceral fat, some of these other things that, of course, they're going to also influence cardiovascular disease risk. So what we think is happening is that after a certain amount of time, from menopause onset, or after you start to develop endothelial dysfunction inside the blood vessels, you start to develop heart disease and dysfunction, then those receptors in the blood vessels for estrogen change. And so that when estrogen binds it, it doesn't cause some of the same probably direct blood vessel effects that you had before. So maybe you still get the indirect effects. Maybe you still get the, like reduced visceral fat and lipid effects and things like that, but you're not getting the same direct effects. And so far in the studies, late start estrogen does not seem to reduce cardiovascular disease risk as far as we know.
Yeah, it's really interesting. And hopefully we'll learn more about that in the future. I think the brain was another area pretty well established, like when you have cognitive maintenance if hormones are continued, but then actually if you reintroduce estrogen, the outcomes were not as good in the brain health.
Yeah, it seems like late start estrogen in the brain and the heart don't prevent further disease. Doesn't mean it makes anything worse. It just doesn't prevent disease. And so in late starters, I do still start estrogen late, but I always start a transdermal, not an oral in those cases. But I use oral estradiol in other cases sometimes. But I do think, I do know that we have other benefits, like your bones, for instance, don't seem to have that problem. Like your bones are happy to have estrogen. If you're 75 years old and haven't had it since you were 50 and you add estrogen, even a small amount, your bones are like, thank you. And they love it. And they, it actually can help to prevent, further bone loss and even improve bone building, even in late starters. Same thing with the pelvic floor and, and urinary symptoms. So some systems seem to not have the receptors change, and others seem to have those receptors change after time, which is very interesting.
Yeah, you're bringing up for me this thought about like just listening to you talk. It's like, this is why women need doctors who sit with them and understand what their needs are and what their life is like and what their risk factors are, because there's not, while we have these guidelines, what's really standing out to me is there might be cases where you'd go outside of guidelines. Like if a woman's had a long period of time between menopause and wanting to start hormone therapy, depending upon her risks and her quality of life. And it's about shared decision-making and having a doctor who helps you understand what the risks are, the benefits might be, and like really making that decision together. And I think it's hard to find, but it's so, so important.
It is hard. It's hard to stay up on all this information. I do this, almost full time, and it's still hard.
Now, another thing that I thought was so interesting, you shared this study from Nature that came out this year, this like multi-omic study, where I want, first of all, you to explain what that is, because I think a lot of people are new to the concept of these markers that can be picked up to look at, but it's part of longevity medicine. And it was interesting because they kind of compared that individual organ markers to the kind of overall biological age calculations that are being done too. So anyway, I know this, you know so much more about this than me. Can you tell us a little bit more about just this field of measuring lifespan, health span? Let's start there.
So in the longevity space, a lot of people talk about these aging clocks. In fact, I was just at a conference in Switzerland. The whole thing was about aging clocks. And you have people like Steve Harvath, who kind of invented one of the first aging clocks. But these clocks there's different ways of, looking at your body and trying to say, what is the age of either the body or the organ? And so they can use epigenetics, for instance, the decorations around the DNA that of course change as you get older. Those can give you an idea of this like biological age. But there are other things you can use, like the glycans around your immune molecules, the proteins in your blood, the RNA in your blood. So all of this whole category is called metabolomics, essentially doing some sort of testing of these various pieces of the body, the metabolism, the DNA, the genomics, and then trying to understand what is the biological age using that category. So what this study in Nature did was they essentially were looking at all kinds of things, but they started looking at menopause and the effect of menopause on various organs' age. So they looked at these metabolomics, and they would look at the age of your heart or your brain or your liver or your immune system, and how does menopause affect the age of those systems. And they found that almost across the board, menopause was detrimental it made all those systems age faster. And then they also said, well, what about estrogen therapy? How does that seem to affect those systems aging? And they found that in most systems, especially the immune system, the liver, and I think one other one, I can't remember what it was, that it slowed down the aging of those systems.
Was it pancreatic?
It might have been. I can't remember. I know it wasn't heart, because heart actually wasn't. Oh, blood vessels. It was blood vessels.
Oh, blood vessels. That's
blood
right.
vessels. So blood vessels, liver, immune system were very susceptible in a good way to estrogen, and they would actually slow organ aging when you got estrogen compared to not having hormones. And then there were other systems that didn't seem to be as affected, like muscles were not that effective, as affected by estrogen.
That was surprising to me that muscles weren't as affected.
I know. I was kind of surprised. And even heart wasn't that affected.
Right.
Blood vessels were, but heart wasn't. So, this is one of those things that I think it's important to understand, because we don't necessarily have to wait 10 or 20 years to see how a therapy is working if we have tests like this. And, one of my favorite tests is the glycanage test because it's very receptive to estrogen status in the body. And it's a test of inflammation of your immune system. But when you add estrogen, if you need it, it can markedly affect this glycanage test. And so I think that tests like this can be really helpful for doctors once we know how to use them and once we can kind of prove that they're actually, precise and accurate, which right now there's a little bit of question about that.
Yeah, like I know this study, the number of women was very small. It was like 47 women. So
Yeah.
but it was exploratory and it's so interesting.
Right.
And it's a really great step on the pathway to trying to learn more and learn how we could do this type of work in a scaled way.
Yeah.
The other thing in that study that I found really interesting was women who went through an early menopause had a much greater speed of organ aging. And it makes
Yeah.
me think about, I have a fertility background, most of my clinical practice, and it's like patients with bad fertility tend to have worse morbidity and like
Yes.
worse outcomes with chronic disease, but it's not the infertility that's causing it. It's the thing that causes the infertility that's also causing this
Yeah.
kind of chronic disease. And it makes me think about early menopause and the way we think about that, whether it's true premature ovarian insufficiency or whether that's like a gray version of that, if that's black and white, some kind of in between where our ovaries. And actually, there was this kind of cool paper that came out about just the environment within the ovaries and the way that changes with aging. It's not so black and
Yeah.
white. So we're really starting to kind of hone in on that.
Yeah,
But
I think it's so interesting the role that the ovaries and the eggs play in women's longevity. And I think that anyone who's studying longevity, if you're studying women, if you're not talking about the role of the ovary, then you're missing a huge part of the picture. Not the whole picture, but a big part of it. And like you said, like, ovarian aging, the speed that our ovaries age, it is not something that, is the same for everyone. And environmental factors, lifestyle factors, genetics, of course, but many things influence how quickly the ovaries age. And so those are important. But then also, once the ovaries have kind of aged out and you've hit menopause or premature ovarian insufficiency if you're younger, then that's also going to have a big impact on how you age. Also, it's kind of like your more rapid aging sets in when the ovaries kind of stop working. So it's kind of a chicken and egg, and there's a lot of things happening at one time. But the role of the ovaries in how quickly women age in multiple body systems is well known, but we're learning more about it all the time.
yeah, I mean, if I had to summarize it quickly for the sake of, a clip, it would be that mitochondria really drive ovarian function. Same with testicular function in men.
Yeah.
When we learned about mitochondria in medical school, I always learned about it with the cardiovascular system. It's like, the role of the way that the heart needs so many mitochondria, and you take CoQ10 for your heart and all this stuff. But really, the organs that are most dependent upon mitochondria are testes and ovaries. And so it's so interesting because I think as we have poor lifestyle, high stress, poor diet, high insulin, all these things impair our mitochondrial function. And then we start to see change there first. It's like the canary in the coal mine. So,
Yeah.
I think as we roll back, it's like protect the mitochondria to protect your ovaries, to protect your
Yeah.
hormones and your long-term health.
And also, estrogen is integral to how mitochondria work. So, if you get to the point where you aren't making estrogen and you also aren't taking it, then you're going to have worsening mitochondrial function system-wide because it's no longer getting that positive signal from estrogen, which is a positive marker of how it helps mitochondria work better. So there's it's such a dynamic, interesting process.
Yeah, definitely. Now, when it comes to the stem cell therapy piece, in your clinic, you'd mentioned that was used predominantly for like injuries or pain. Is that right? Or are you seeing that there could be applications for stem cell therapy for overall longevity and benefit? How is that different than the kind of targeted treatment?
Yeah, I mean, so both can be done for sure. So in our doceria clinics in Park City, we're using primarily localized treatments. So for skin health, scalp health, sexual health, and then joint health, and injecting it into those areas. But we also at that clinic, as well as at Humanot, will also do intravenous, either stem cells or extracellular vesicles like exosomes. And there is some research looking at longevity and after stem cells and in stem cells potentially helping with markers of longevity. Most of the studies that have been done used like umbilical cord stem cells and looked at older people who had frailty, and they would say, if we give you IV stem cells, does this help with markers of frailty, like how far you can walk in 6 minutes or your grip strength or things like that. And it did seem in those small studies that the stem cells were helpful. Mechanistically, it makes sense. We don't have large studies, and certainly not like large randomized control trials that say that IV stem cells or exosomes or things like that increase longevity in any real way. But we think that they could.
It's exciting to think about because it's an area of, we focus a lot on removing injury, like reducing inflammation,
Yeah.
kind of creating a better environment for health. But when it comes to actual like cellular repair, that's something that we do on our own. Our bodies know how to do that. So thinking about ways to optimize that beyond just changing the immune system's kind of external function, but truly the cell's function is a really interesting piece we've not unlocked. It's kind of the last piece of the puzzle to unlock, I think.
Yeah, I think it's really interesting. And then pairing it with other therapies, pairing it with hyperbaric oxygen or, a therapeutic plasma exchange or some of these other things that have come online more in the longevity space in the last few years. Like how do those work together with stem cell therapies? And then obviously pairing those all with a good healthy lifestyle and all the things that we know work just in general for health.
Yeah. Now you mentioned like hair and skin as well. And I want to ask your opinion about this because I see a lot that longevity medicine and aesthetics get kind of partnered in a practice. And so
Yeah.
I really would love you to share your perspective on this kind of like outside and inside kind of pairing of work and how that benefits women or why clinics are doing that for the sake of women.
Well, I can tell you why I started doing it. So when I
Great.
started doing hormones in Portland at a small clinic, I was like a one-man show. I was running the whole clinic by myself. I didn't have any help. It was very funny. But I was seeing patients, and when I would first see them, they would come in kind of in this, survival mode. Like I'm sure you've seen, like they're stressed out and they're overweight and like nothing's working and they're at the end of their rope. And so we would start some lifestyle changes, some supplements, some hormones, and then they would come back in 3 or 4 months. So they're starting to feel better, and they're like, okay, I'm losing a little weight, my energy's up, and they would invariably then ask about one of two things. They would say either, now can you help me with my sex life? Or they would say, now can you help me with my skin and hair? And so I got the question so many times that I started thinking, like, what can I do? Like, I'm not a dermatologist, I'm not a urologist, but surely there's some connection between all the things that I'm learning about in terms of how to be healthy and helping people with, skin, scalp, sexual health. And so I kind of started diving in and learned, all the things we could do from a lifestyle standpoint, but then the other regenerative therapies that were kind of coming online at that time, PRP and then eventually stem cells and shockwave therapy and red light therapy and, all these other things.
What are your favorites for skin? Because there's so much out there that I think women are like, it's hard to kind of cut through. And you look at like the red light therapy masks, they're hundreds of dollars. Like no one wants to spend money on things that aren't going to work. Yeah. Are there things that you feel like are really trustworthy recommendations in this space?
I mean, sunblock is probably the most important one.
I wish I took that on like 20 years ago.
Yeah. And I love the sun. I think the sun does have some good benefits to health. I think we should be getting some sun every day, but probably not on your face. And, and now like my neck, I always forget my neck, and now it's like getting brown. Anyway, sunblock, mineral sunblock every day is important, I think. I think a retinoid of some sort before bed, we has a lot of data behind it. We know that this is a good for slowing skin aging. There's various antioxidant options out there that can be helpful as well. Kind of pair that with the sunblock. The block is helping to prevent the sun damage, and then you add in something to help repair the damage, like vitamin C and vitamin E and resveratrol and some of these NAD precursors, etc. So I think those are the main things, and then there's certainly many things that you can try on top of that. But getting the basics right is going to get you a long way.
That's good. And a lot of those, like the retinol, you can get prescriptions that are not out of like high cost out of pocket to the patient, which I really like. Like a tretinoin you get a copay for that. It's not like you have to pay $300 a month for some fancy skincare cream and you get a lot of great results.
Yeah. I mean, I think I get my tretinoin for like $10 and it lasts me, 2 or 3 months. And so you just get a little tiny bit at a time. It goes a long way.
Yeah. Great. So I do want to talk a little bit about the Dutch test, if you're open to it.
Yeah, sure.
And I have to tell you, actually, our team probably sent me your post and you put up like, should I take a Dutch test? And I thought it was really, first of all, it was very fair. And I really appreciate the way you took the time to do the research. And like, I could tell you really looked into the research. In fact, I wish we had your spreadsheet when we had done our webinar, which was like 6 months before you put that post up. But I really, first of all, wanted to say I really appreciate it. And I know your post talked about estrogen metabolites specifically. Yeah. Why did you look at estrogen metabolites? Is that what most people associate the Dutch test with, you think?
Yeah, I think that, first of all, when I went into this, I've been for years, I've been wondering, like, should I be doing this test? And I think that there are potentially benefits to the test. I just wanted to make sure that I understood what they were. I have many doctor friends in the functional medicine space who like love the Dutch test and they do it all the time. And they're like, if you're not doing it, you're not even doing hormones right. But I've also kind of heard the other side, and I chose estrogen metabolism and breast cancer because mostly I was curious about the relationship. I'd been hearing, so many times that this pathway causes breast cancer and this one's healthy and this one's not. And I didn't know if it was true. And what happened when I started looking into the research, I found that a lot of studies were referencing other
Each other.
articles, but very few people had actually gone back to the primary studies to see what the primary studies had shown. And so that kind of became my like 6-month mission. Like, let's go back to the primary studies and read them all and see what they showed, and then try to understand what this test can tell us and what it can't.
Yeah. Well, I went through your spreadsheet as well, and because we did the same work. I mean, we really try our best to be evidence-based, and hopefully people know that. Like, we care about science. In fact, Mark, our founder, used to work for a saliva lab. I don't know if you know that, a saliva hormone testing lab. And he was responsible for like creating all the education. And eventually he went to the owner and said, I don't think saliva is the best way to measure hormones. And the guy didn't really want to do anything about it. So he founded a urine-based lab and developed that method. And so he was like, I taught saliva for so long, but then when I looked into it, I didn't feel good about it. So I went to urine. And I really respect that, actually. And I remember actually Tara Scott asked Mark a question and shared some data, and we looked at it. It was a completely different topic. But Mark said to me, and I'll never forget this, he said, my worst nightmare is to know that we've like sent anyone down the wrong path with any clinical decision, right? So we really do. My point being, the reason why I like working there is that I do trust that that we look at their research and would pivot if things didn't look like we were going the right direction. That being said, so we looked at your spreadsheet. We'd done that literature research before and seen most of the same studies. But one thing that I want to highlight is that, and I learned this a lot working at Dutch, is that method matters for hormone measurement. And when I looked at the research that was looked at, most of the studies that showed no benefit used an immunoassay for the hormone measurements. The ones that showed better connection actually were done with LCMS. And that's something that I think a lot of clinicians, like, I hope you don't mind me using this opportunity to bring it up.
Sure.
Because people don't know, like us as docs don't know to ask, even in serum, when you're expecting low levels of hormone, like measuring estrogens in a postmenopausal woman, you're always better off to ask for LCMS because the sensitivity is there, where immunoassays are not typically as sensitive. That's one of the challenges with saliva, is there are LCMS methods, but not commercially available. And so with saliva, they're using immunoassay. So that was really, I just would offer that as like a layer to consider, because then we filtered out a lot of the studies that you included because they were immunoassay. But the last study, I think was Brantley was the author. That one really, like, we're spending some time looking at that one because that was LCMS and didn't show a connection. And that was an outlier. So that was a newer paper since we did our review. So I really appreciate you bringing that one up.
And I'm glad that you said that, because I did try to, I went through and noted how if I could find it, how they actually calculated the levels. And to your point, immunoassay is notably in the hormone space not as good as LCMS. And we've seen that, especially for like progesterone. Immunoassays were overestimating progesterone by 3, 4, 5-fold for years, and we had no idea. So I think that is a fantastic point, and I think how you measure definitely matters. And I think that my takeaway wasn't necessarily that the hormone pathways, that the 2,4-hydroxy don't tell us anything. My takeaway was more that I don't know that we know as much as we think we do, and probably there's just more, like, probably as we continue to gather information from women, what are their genetics, what's their lifestyle, what's their epigenetics, as we gather all this information together, and then use some of these tests like the Dutch test, I think we'll start to understand why we're seeing this, benefit or this effect in some people but not others. But I just don't think that it's as easy necessarily as saying this pathway is good, this pathway is bad, end of case.
I completely agree with you, and I really align with what you're saying with that. And we actually we stopped using that like good and bad language, which again was never technically correct. It just simplified the message and helped people understand. But we now say like preferred, because I think we believe from the research that we could say that the 2OH pathway is preferred because it doesn't make reactive quinones that can damage DNA compared to the 4-hydroxy pathway. But I think you're totally right in that making the leap to this is associated with cancer. We're not there yet with the clinical research. I totally agree with you. And I'm very sensitive to overstating anything either. We want, like then we want to be aligned with the science. We'd like to be cutting edge with it, but we do want to make sure that it's aligned. But we do think that based on the literature, there's a preferred pathway for estrogen metabolism versus not. And it's an interesting thing to be studying.
And I will say that my doctor friends who are in this space who use this test a lot, they will tell you, well, we know that the 2-hydroxy is a better pathway because when we get our patients to eat healthier and cut alcohol and cut smoking and do all the things, then they will move more towards that 2 pathway. So that makes sense. That's a healthier pathway. And so I think that makes sense. I would love to see more tests with patients who actually are on hormone therapy, of the ones that at least from what I could see, only 4 or 5 of the studies even included people taking hormones.
Oh, you're totally right. That was a great call out.
Hormones is a whole different beast than your body's making hormones. And so, when I'm thinking about, doing a test like the Dutch test, it would mostly be, because I mostly treat women in perimenopause and menopause. So I'm not treating younger women. So most of my patients are either on hormones or they probably will be soon. So how do we use tests like this in women who are on hormones? Are there things that are different that we should be taking into account? And I think we just don't have enough information about that yet, but certainly would love to know more in the future.
Yeah. The way that we think about it for hormone therapy, we can take this offline, but I think people will be interested if they're listening, is I think that, well, there's 2 things. One, I think that monitoring can be helpful for women on hormone therapy if you're thinking about trying to achieve goals beyond hot flash management. That's a controversial hot take. So people could disagree. We're going to get it in the comments. People are going to disagree, and that's okay. It's outside of standard guidelines, but it is the only kind of hormone family we don't test when we put people on hormones. We test men on testosterone, we test thyroid. And I really think that's due to a couple of things. One is that if you're looking at symptom management, you don't need to monitor. You can just ask the woman, are your hot flashes gone? And if they are, you're in a suitable range. And the second is I think serum's a terrible way to monitor. We don't have a good tool for it. But serum's great if you're on a patch, maybe, where you get a steady state level. But with pharmacokinetics, with oral or a transdermal cream or gel that you're applying every day, you get this up and down pattern. And
absolutely.
It's different. You like 6 hours, 8 hours measurement later, it can look so different from woman to woman. So I think that we have limitations in testing, which this is one of the reasons I get excited about the Dutch test, because you get a 24-hour window with 4 samples. So you actually catch the whole pharmacokinetic curve. Yeah. And that, I think, gives you a better estimate. So I think if you have a tool, and then you can ask, should I use that tool? And when we look at did you see Sarah Glynn's study in menopause? And I think it was February of this year out of the UK, where it was actually shocking to me that she was looking at the NHS available, like commercially available estradiol products, and whether women on different doses reached the targets for osteoporosis prevention. And even at the highest doses available, about 30% of women did not hit that target, which was, I was really surprised actually.
Yeah,
that it was so high.
Newson and Glenn. Yeah, it was fascinating. And they were all using transdermal applications, but you're right. Whether it was gels or patches, a lot of them were on max pharmaceutical dosing, and they still had very low, at least serum estradiol levels, which was very interesting.
Yeah, and there was this other study that I've looked at before, and I can't remember the name of the author. I'll put it in the show notes so people can take a look at it. It was very small. It was only like 19 women. But he actually did pharmacokinetic tracings for women like on a patch, and then he would put them on a gel. They didn't use compounded creams. But then you could see that some women like absorbed the patch, but not the gel, or they absorbed the gel, but not the patch, or there was just this like different pharmacokinetic absorption pattern. And again, it's very small, but I found that so interesting. And anyway, those things together make me think that the assumption that women all absorb estrogen the same way is probably
I totally agree. I think that's a very valid thing. And I think, I did an article recently on Substack about the pharmacokinetics of some of these hormones, and it is very confusing. So I totally agree.
It's so confusing.
I do think that serum estradiol levels are helpful, but I also think you have to know what you're looking at. And unless
Tell
you
me how you use
understand-
them. I'd love, can you share how you use
Yeah,
them?
yeah. I mean, I use them, with understanding what the pharmacokinetics are for whatever hormone I'm giving. So patch is pretty easy because you do
Yeah.
get this pretty even level for 3.5 days. But if it's anything else, if it's an oral pill, if it's gel or any cream, transdermal cream, then you are going to get this peak thing, and it's going to come down. Usually, once you reach steady state, you're not going to have obviously as many ups and downs. It's going to be kind of up and down in a smaller range, and that range is a little easier to, once you understand what that range is, then even if you were a little bit off in terms of when you draw it, then you're still going to be in that steady state range. So for instance, maybe your estradiol is 60 one time and 85 the next time. But if you're in that range from 60 to 100 or 65 to 120 or whatever that serum estradiol range is, then to me, I'm good with that. I do want to see that you're hitting that like 65 or so picogram per ml serum level, because I think that is what no one else agrees with me. I'm not, the guidelines don't agree with me, so this is just me, but I think that that's the level that we want for bone protection and maybe even regrowth of bone, as well as cardiovascular protection. So I'm aiming for that, but keeping in mind, when they're taking the medicine, when they're checking checking the dose. So you have to understand, when the hormones are taken, to understand how to read those numbers.
Yeah, I love that you say no one agrees with me. This is just how I do it, because honestly, like that's how clinical medicine advances, is you kind of observe your patient population and you start to do what works over and over again. So that's not a bad thing. You said that like it's a bad thing.
It's not like, I'm not like off the reservation. It's just I think
No.
that you have to, but I totally agree with you that serum estradiol levels are confusing. Serum progesterone levels are also pretty difficult to make any. Oral progesterone is mostly gone by the time you check it the next morning in the blood. So I understand the need for other testing.
Yeah.
And so I'm on your side on that one.
Yeah, thank you for just honoring having this conversation, because I think we want to be open to constructive criticism. We always are, and I really I felt the true sense of where you were coming from when you put that together, that it was well intended to really provide good information. I think it really did provide good information. So thank you for that.
I appreciate that.
Yeah. So I think my last question for you, Amy, is what are you most excited about for women's health? Like for all the things that are coming down the line that are becoming available to women that you can access in most major cities. Are there elements of care that you're really excited about growing?
I mean, honestly, I think I'm most excited about having more women getting access to just basic hormone optimization therapy. Like we can move from less than 5% of women in the US, over 50 getting hormones to 80% or 70% or something that is, more reasonable. We will help so many women. We will prevent so many diseases, and we will help women to feel better now, which I think is a huge win for the female population. In the distant future, I'm really excited about some of the ovarian aging research that's going on and trying to, delay ovarian aging and, even potentially prevent ovarian aging. So I think that's a really cool area of research. But for right now, let's just get women the hormones they need.
Pretty simple and readily available. So I hope we get there. I really appreciate you joining me today. Thank you so much, Dr. Killen.
This was so fun. Thank you.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.